Welcome to another PrecisCa tumor board. We've got several cases to discuss today, very good cases with some challenging questions and some interesting decision-making pivot points throughout the care of the patients presented here. I just want to start with some introductions before we get started. I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a lung cancer specialist and also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We'll just briefly go around and I'll allow each of you to introduce yourself. So I'll start with Dr. Keston.
Yes, I'm Larry Keston. I'm a radiation oncologist. I'm a clinical professor at Wayne State University in Michigan. I work for Genesis Care, and I am the medical director of radiation oncology in the Michigan region. I also am the director of, I'm the chair of thoracic radiation oncology for the American Board of Radiology.
Hi, I'm Dr. Jack West. I'm a medical oncologist focused on thoracic oncology. I work as an associate professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. Happy to be here.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology at Memorial Sloan Kettering Cancer Center. And I'm also a professor of radiology at Weill Cornell Medical College and a vice chair for education at Memorial Sloan Kettering Cancer Center in radiology.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
So our next case is a stage 4 adenocarcinoma patient with high PD-L1. So 71-year-old Caucasian male, former smoker, more than 65 pack year history with a history of stage 4 lung adenocarcinoma involving the left lung and bone metastases. He's gotten chemoimmunotherapy. With most recent progression on atezolizumab, his PD-L1 is 5%. Other mutations are negative. This case is deep into the weeds for medical oncology. And we can talk about or argue what this patient got and whether we would have given it or not, but I want to focus more on what we would do next if this came to our clinic at this time. So the question here is, what would be the next recommended line of therapy in a patient who decides pursue further treatment? So this patient's original presentation started with right scapular and arm pain. The patient has a performance status of 2. He has a medical history of arthritis, chronic back pain with right-sided radiculopathy, foot drop, wears a brace. He has hypertension, anemia, and neuropathy. He is a former smoker, quit back in 2015, occasional alcohol, no illicit drug use. Family history, no history of lung cancer. Again, a father with colon cancer and a mother with non-Hodgkin's lymphoma. In April 2020, he has a roughly 4-centimeter spiculated mass in the left upper lobe with adjacent left hilar mass. The PET scan shows this left hilar mass with an SUV of 9.3 and at least 2 lymph nodes with increased activity. He unfortunately has a first right rib with a lytic destructive lesion with an SUV of 9.8 and a metastatic lesion in the right iliac bone. This is not an uncommon presentation given the proclivity of lung cancer to go to the bone. He gets a right iliac biopsy, and we can talk about that. That's consistent with metastatic adenocarcinoma with mucinous features, compatible with lung primary. The mutational panel on the bone biopsy is negative. The PD-L1 is 5%. The patient, due to his pain, completes radiation to the first rib with a dose of 3,000 gray in 10 fractions and initiates the Keynote 189 regimen of carboplatin, pemetrexed, pembrolizumab with a bone strengthening agent with zoledronic acid. Now, patient has a repeat PET scan. Let's see, this was done in April. So in July, the patient has a PET scan that shows improvement of disease. Patient completes 4 cycles of this triplet therapy with carboplatin, pemetrexed, pembrolizumab, and then gets maintenance pembrolizumab and zoledronic acid. 5 months later, unfortunately, the PET scan shows progression of disease in the left upper lobe and concerns for osteonecrosis of the jaw. The bronchoscopy is done with repeat biopsy for next generation sequencing, showing no actionable mutations, but a P53 and an RB1, STK11. We can potentially talk about the relevance of these P10 and a SMARCA4 pathogenic variant. The zoledronic acid is stopped, I assume, for potential osteonecrosis of the jaw. Second line therapy. So the patient has gotten carboplatin, pemetrexed, pembrolizumab, and then went on to maintenance pembrolizumab, but had disease progression. This case, he gets carboplatin, paclitaxel, pembrolizumab. And 3 months later, unfortunately, another scan, both CAT scan and PET scan, show increased size and FDG uptake of the left upper lobe tumor, no new Mets. Switched to third line atezolizumab, and then completes hypofractured radiation to the left upper lobe lung primary to 6,000 gray in 10 fractions. 2 months later, patient has CT chest with destructive lesion at the 7th rib on the right side. PET scan with stable disease other than these new rib metastases. So maybe we can kind of go over, let me just complete here. So the July 2021, this is a long case, completed palliative radiation to the 7th right rib. And then in October 2021, the PET scan is done that shows development of scattered large and small pulmonary nodules consistent with pulmonary metastatic disease, worsening osseous metastatic disease, and the development of a small right pleural effusion that's likely malignant with a worsening performance status. So I know you don't have much here, Dr. Ginsburg. I assume this is the CT part of the PET scan from October 2021 that we're looking at here.
Right. So this is the CT with intravenous contrast from the PET CT, and the arrow points to the lytic destructive rib lesion of the 7th rib with the associated soft tissue mass. We also see a small right pleural effusion. And then while these are not lung windows, we still could see that they're bilateral pulmonary nodules that measure up to about 1 centimeter in size.
Great. All right, Dr. West, I'm going to summarize this the best I can. So initial treatment with carboplatin, pemetrexed, pembrolizumab. Unfortunately, disease progression, then on another triplet there. Unfortunately, disease progression placed on carboplatin, paclitaxel, pembrolizumab, develops disease progression again, receives atezolizumab. So it's gotten 3 lines of therapy, has had along the way 2 next generation sequencings done, one on a bone biopsy that was did not unearth any actionable mutation, a second bronchoscopy where we saw an STK11, P10, a P53, and an RB1, has had interspersed throughout this palliative radiation, comes to your office. What are you thinking here? We don't know, we don't have the eyeball test here. We don't have what his performance status is other than say it's worsening. We see that he's got a lot going on here. How do you approach a patient like this?
I think, I believe earlier on there was a reference to his performance status being 2. And so I think it is no better than 2 and maybe on the worst side of 2. So I think it's appropriate to be asking what is left to do and what might represent treatment where the treatment could be worse than the disease. And I think it is appropriate to consider supportive care and a focus on symptomatic management as an option to strongly consider and not consider just a consolation prize here. I would note that he did have RB1, and it would be nice to have a pathology review just to make sure this isn't small cell lung cancer now. I mean, there is certainly a significant minority of lung cancer that is a mix of small cell and non-small cell. And I don't know how practically that would change things that much, because it's not as if the chemo immunotherapy he received would have been a terribly poor treatment for small cell either. Even if it wouldn't be your ideal top choice, you might consider a different agent like lurbinectidine or topotecan, but those are not ones that are so amazingly effective that I would worry too much about it. I would note he has not had, that I can see, progression on pemetrexed, and so in the back of my mind, I think that remains an option. And then docetaxel-based treatment, which has some activity in both non-small cell, where it's really a cornerstone of treatment for previously treated patients. it can be difficult. And I think I would be very forthright with this patient that it can be challenging every 3 weeks, even on its own. But especially if we were to maybe add ramucirumab, which is an appropriate consideration, a slight improvement in survival. But this is difficult even in patients with performance status of 1. And I think if someone's performance status is 2, 2.5, or 3, I think it's a real risk that the patient will have a very challenging time with that. But I would present that as an option as well. You could also consider gemcitabine alone, or potentially even combined with vinorelbine. Not really well studied there, but it's mentioned in the NCCN guidelines, but not associated with a survival benefit. And I would really consider that to be more treatment for the sake of trying something, but not something that I would say has a compelling enough track record to favor that over the other options we might consider. And again, I would say that transitioning to focus overwhelmingly on supportive care and palliation is an appropriate option to really rank among the options.
Yeah, great summary and well said, spot on. I think these are the difficult conversations we have in our clinic. This is where I talk about shifting the goals of care. I think it's a consideration. I'm not saying we had to do it, but potentially looking towards supportive care and symptomatic management versus treatment. I don't think we've got great data at this point that any treatment is going to improve survival, although one could argue for it. One could sit down. This is where we get back to Dr. Force's comment about shared decision making and what are the expectations and shared expectations moving forward. So I think well stated. So let's just summarize here what we would do. I think number one, certainly a discussion about supportive care and symptomatic management and shifting away from just treating. If the patient and family, I think, is also important, if they're participating, want to receive treatment. I love the idea of pemetrexed, because you're right, the patient didn't get pemetrexed in the maintenance strategy, only got pembrolizumab.
Yeah.
I think that would be my first choice, and I agree that the other options are taxane based with or without ramucirumab, maybe gemcitabine.